Dear friends, we are going to talk about controversy in stroke and how the literature helps in doing better treatment for our patients. Now, ICAT, intracranial stenosis, there is a controversy. Risk of stroke is high, but the guidelines are that only we do stenting only when there's a recurrent event on medical therapy. But should we be waiting for second event in all of these patients? Now, there's a very nice study published in Stroke Journal. And in this 5-year-old data, questions our recent current practice of waiting for second stroke and tells us which kind of patients may do better on primary stenting. So when we are qualifying the infarct into three types, border zone, core MC, or perforator infarct. So what they have seen is that the border zone infarction is there when the risk of stroke is around 25 to 28% at 2 years and 3 years. That means in this kind of group, border zone means watershed infarction. And in this kind of group, the recurrent stroke risk is very high as compared to the core or perforator infarction. Similarly, when the collateral flow is impaired, what they've seen again, the risk of stroke is very high, 26 to 30% or so. So when you consider both these in combination, border zone and poor collateral, the risk goes up to 37% or so. So what we want to emphasize that these are the kind of patients who are going to do pretty badly and very high risk of stroke on primary medical therapy. And in this kind of group, it has been shown that they have much more favorable outcome in stroke when we did the stenting after the first stroke itself. Just to show you a case, typical case like this, MCA stenosis, patient had border zone infarctions as well, severe MCA stenosis, poor flow in the MCA, and one can see there are a lot of collaterals. The 3D shows the stenosis quite well. And after we did the stenting, one can see the hemodynamic change, good antegrade flow, disappearance of the collaterals. These are the kind of patients, a typical case which will do badly on primary medical therapy, and we should consider stenting in these patients. So just to conclude that please consider the imaging, border zone infarctions, angiographically, poor collaterals. These are the high risk, and we should think about primary stenting in these patients. And we need not wait in all of these patients for the second event as well. Thank you very much.